So here's another topic that's very common in our emergency setup. Let's talk about acute exacerbation of asthma. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to look at acute asthma exacerbation. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper and your pen and let's go. Before actually going to the acute exacerbation, let me just remind you a little bit about asthma. I know I may not have covered this topic in depth, but I will cover it in depth later on in the chapter, but I just wanted to focus on the emergencies first. So remember that asthma is actually a chronic inflammatory disorder. Previously was classified as a COPD, but the difference between COPDs and asthma is that asthma is largely reversible. The COPDs, the damage that they cause is largely irreversible, even on the initial aspect of the condition. That's why it was reclassified and removed as part of the COPDs. So you get this chronic inflammatory disorder that's going to be affecting the airways, and there's going to be this airway hyperresponsiveness that's going to eventually lead to this recurrent, the key word is recurrent, persistent episodes of wheezing, breathlessness, cough, dyspnea, and chest tightness. And usually these can be triggered, and usually there is such seasonal variations and even day variations with the symptoms which come and go. So remember, the symptoms are going to be associated with a widespread variable airflow obstruction, which is at least partially reversible, either spontaneously, which just remits on its own, or using certain drugs that we will talk about in this lecture. So remember that the inflammation causes airway hyperresponsiveness to many of the different stimuli, and asthma is the most common chronic pediatric disease. 50% of children are actually going to get symptoms by 1 year, 90% will have symptoms by 5 years, 30 to 50% actually go into remission by puberty. And remember that acute exacerbation of attacks often are going to be following certain triggers. And these triggers are going to include things like infections. Remember, whenever you get especially viral infections, you have these things replicating in your respiratory cells, and eventually they're going to interfere with the integrity of the mucosal surface. So this is going to be caused by opening up of the tightened epithelial cellular junctions, and this is also going to induce shedding of the epithelium. This is one of the things that can actually trigger an asthmatic attack. In order, children, exercise can actually trigger an asthmatic attack in genetically susceptible individuals. For example, when you exercise, your respiratory rate is increased. Every time you breathe out, you lose this water from the respiratory tract. So this can actually induce the mucosal hyperosmolarity, which can actually stimulate the mast cells to release the chemical mediators like histamine that can actually cause bronchospasms. Then the weather, also cold weather, cold air, loss of water, and even heat from the lower airways, and even sudden release of airborne allergens in the atmosphere can also trigger an asthmatic attack. Different emotions. Remember, when you get, especially with the bad emotions like crying a lot, extremely sad emotions, there's increase in the vagal output, which can also cause bronchial smooth muscle spasms. Allergens, which may be seasonal, like pollen, green, and even non-seasonal animal feathers. Dust mites, molds, as well as food proteins or additives, peanuts, a very good example, can actually also trigger an asthmatic attack. Gastroesophageal reflux, exposure to pollutants, endocrine factors. Remember, some endocrinal changes like puberty may actually increase the symptoms of asthma. So what's our diagnostic criteria for asthma, just in short? Remember, you're going to have these episodes of breathlessness, chest tightness, wheezing, a persistent cough in some cases, airflow obstruction, variability and reversibility by peak flow measurement or spirometry. Once you have these certain things present in the child and they are recurrent, then it makes asthma much more likely, and there will also be a family history. So what's our approach to our patients? Remember that patients are going to come in with this acute asthmatic attack. So you always want to treat that, because if it is left untreated, the patient is actually invariably going to die. It's actually life-threatening. So once you have actually treated them and stabilized them, then you can take your full history, you can perform your physical examination, you can formulate a definitive management plan. So once you have now treated this patient and you suspect that maybe this could be asthma, you should ask the following questions. You should ask how frequent these symptoms are present, what triggers the symptom, what triggered the symptom, specifically, for example, sports or even general activities that are affected by asthma. How often do they sleep gets disturbed by asthma? How severe are the interval symptoms between the exacerbations, and how much school has this person actually missed due to the asthma? This will give you a good idea of how well controlled or poorly controlled this asthma has been. Then asthma is also going to be graded according to severity. So remember, we're going to grade it as mild, moderate, severe, and life-threatening. And remember, it's very important that whenever you're assessing the severity, you look at certain things. One such important thing is the level of consciousness. Another thing are your vitals. So your respiratory rate, your heart rate, your oxygen saturation. You also look at your respiratory effort and the color of the patient, if there's any presence or absence of cyanosis. These things will help you gauge whether this person is having a mild exacerbation, a moderate exacerbation, a severe exacerbation, and a life-threatening exacerbation, because management of each of these types of acute asthmatic attacks is slightly different. So remember that whenever someone comes in now with a bracket of an acute asthmatic attack, you won't even have time to actually send the patient to go get an x-ray, because unless if you have an x-ray portable in your department, but most departments in our setup don't have x-rays that are attached to the department. So usually x-rays are rarely done unless if you're suspecting something like a pneumothorax, a pneumonia, a lung collapse, then you can order for an x-ray, but routinely we don't do it for exacerbation of asthma. Also with ABGs, these are only indicated for patients that come in with acute severe asthma attacks. ABGs are simply arterial blood gases. So we'll begin with mild acute exacerbation. So remember, patients are often going to be breathless, but this breathless usually is worsened by walking. They're fairly comfortable at rest. When you communicate with them, they're able to complete sentences. The patient is fully conscious. They may be agitated, and usually they have either a normal or mildly increased respiratory rate. So if they're between the ages of 2 to 5 years, it's less than 50 breaths per minute. If they're greater than 5 years, less than 30 breaths per minute. They have no features of significant respiratory distress, so there is no use of accessory muscles of respiration. They will have a moderate wheeze, which is often heard only at the end of expiration. The saturations on room air is about greater than 95%. If you do not have pulse oximetry, you can actually use the presence or absence of cyanosis to actually judge. Remember, if someone has central cyanosis, that's actually a very, very poor prognostic indicator and a very indicator of severity. So it means that this person is most likely having a severe asthmatic attack. Then the pulse is usually less than 100 beats per minute, and our peak expiratory flow rate is greater than 80% after initial bronchodilator administration. So this is the bracket of patients that come in with a mild acute asthma. Most of the patients may come in like this. Most of the patients will either come in as a mild acute asthmatic attack or a moderate acute asthmatic attack. So for moderate, they'll have breathlessness when they are talking. And if it's the younger children, they may even have difficulties feeding. They're going to be talking in phrases, so they are unable to complete the sentences. The patients are usually agitated. The respiratory rate is increased. They have moderate respiratory distress, so they have moderate use of accessory muscles with the retractions. The wheeze is often quite loud, and it's predominant on expiration as well. And our saturation on room air is going to be 92 to 95%. Our pulse is going to be 100 to 120 beats per minute, so they're going to be tachycardic. And our peak expiratory flow rate is between 60 to 80%. Notice how it's reducing. This is after initial bronchodilator administration. Then for those that have severe acute asthmatic exacerbation, this patient's actually going to be breathless at rest. The younger children who actually even stop feeding, the patient is going to be talking in words, so they're unable to even complete phrases. And the patient is usually agitated, respiratory rate is markedly increased. So if they are between 2 to 5 years, it's greater than 50 breaths per minute. If they're greater than 5 years, it's greater than 30 breaths per minute. There is severe respiratory distress. There's use of accessory muscles. There are chest retractions. The wheeze is actually usually loud and is present both during expiration and inspiration. And their saturations are less than 92%. If they are above 5 years, usually their heart rate is greater than 120 beats per minute. If they're 2 to 5, it's greater than 160 beats per minute. And their peak expiratory flow rate is less than 60% after initial bronchodilator use. Then for life-threatening acute asthma exacerbation, these patients are not even able to speak. They are going to be drowsy. They're going to be confused. They may be comatose. They may be a poor respiratory effort. paradoxical movement of the thoracoabdominal movement. Remember, they're supposed to be moving in a particular way, but in this case, instead of them moving in the normal way, they are moving in a paradoxical manner, such that when the chest is actually dropping, the abdomen is inflating. When the abdomen is inflating, the chest is actually dropping. The respiratory rate is variable, and there's often a silent chest. This is very, very easy to actually think that the patient actually has improved or the patient is getting better, but actually they're actually deteriorating and getting worse. The patients often do have cyanosis and their saturations are less than 90%. The patient is bradycardic, and often the attending doctor is even unable to perform a peak expiratory flow rate on these patients because, of course, they're in a life-threatening attack, and these patients need help there and then. So what's our admission criteria for all patients that come in with acute exacerbation of asthma? So if they fail to respond to standard home therapy, they have to come in. If they fail to respond, or if they have this mild or moderate acute exacerbation of asthma that has failed to respond to the nebulized beta-2 agonists, we should admit them. If there's a relapse within 4 hours of nebulized beta-2 agonist, we should admit them. If they have a severe acute asthmatic attack and obviously a life-threatening attack, we often do admit them. But the patients that we often see with mild attacks usually are discharged the same day. With moderate, some of them are discharged the same day. Some of them we can keep them for observation and probably even discharge them the following day. Then the ones with severe and life-threatening are usually discharged for some time before we actually can discharge them. Actually admitted for some time before we can discharge them rather. So what's our management? Remember, like I said, the mild attacks, usually mild. We can even treat them at home if the patient is actually prepared. If the caregivers have an action plan for asthmatic attack, they can actually treat it at home. For moderate to severe attacks, these ones are going to require them to go to a clinic or to a hospital. And then remember that asthma attacks require prompt treatment. You do not have to waste time. And remember, this is an emergency. So the first thing that you must do is what I love to ask students why they love ABC so much. But pretty much your airway, your breathing, your circulation whenever they come in to the hospital. And remember, a patient that has brittle asthma, remember brittle asthma is this severe form of asthma where they have this wide variation in the peak expiratory flow rate despite them having heavy doses of steroids, and these patients are predisposed to having these serious and often life-threatening attacks. So patients with brittle asthma, patients with previous ICU admissions for asthma, or patients who are either uncomfortable or judged unable to actually care for the child with acute exacerbation of asthma should all be admitted to the hospital. Whenever you're not so sure, please make sure you admit the child to the hospital, because children tend to change very quickly. You may send them home and they may actually come back in dead on a stretcher. So we'll begin with management of mild acute asthmatic exacerbation. So remember, for mild, moderate, severe, and life-threatening, we all start with ABCs. We ensure that the airway is patent, the patient is breathing, and gain venous access for this patient. Check the RBS for this patient. RBS is very, very important for you to check for this patient. Then assess the level of consciousness in this patient on your disability, so your GCS or your BCS, depending on the age of the patient. It's also very important. So once you have now done this and you have actually checked even the glucose of this patient and know, then if it's a mild acute asthmatic attack, remember this is a teamwork. You can't do this alone, so you call for help. If it's a mild attack, we often just give them 2 drugs. So pretty much salbutamol and prednisolone. That's about it. So with the salbutamol, there are 2 options that we often use. Option 1, we don't use it routinely in our setup at the hospital. We often just go for option 2, which is the nebulization. So I'll begin with the option 2. So we often nebulize them. If they're less than 2 years, 2.5 milligrams of salbutamol. If they are greater than 2 years, 5 milligrams of salbutamol. So we give them 3 cycles back to back. So the first cycle, 2.5 if they are less than 2 years. If they're greater than 2 years, 5 milligrams, then we do it for 3 times. We reassess the patient. If they are improving, then we'll observe them at least for an hour after the last dose. If they are still improving, we can discharge them. And then they continue with a regular salbutamol inhaler at home. And then we'll also continue on the short course of oral steroids at home. And remember that the solution of salbutamol comes in at 5 milligrams per mil or sometimes 2.5 milligrams per mil, depending on the concentration of solution that you have. So make sure that you check. So if you have the 5 milligram per mil solution and you get someone who's less than 2 years, it means you have to take 0.5 mils of this solution. If you have this 2.5 and you want to get a 2.5, you just get 1 mil of this. But if you want to get a 5, you get 2 mils of this. I hope that makes sense. It's just simple ratios and simple pharmacology and simple proportions. Then the other option, if you do not have the salbutamol for nebulization, you can actually use the meter dosed inhaler with a spacer. I'll show you what this looks in the next slide. So we use this if the child is less than 6 years, 4 to 6 puffs. If they are greater than 6 years, 8 to 12 puffs. We give this every 20 minutes for 1 hour, then every 30 minutes to 4 hourly. So remember, 6 puffs of 100 micrograms per puff is going to be equal to 2.5 milligrams of salbutamol nebules. Then 12 puffs by 100 microgram per puff is going to be equal to 5 milligrams of salbutamol if they're greater than 6 years. We also start them on prednisolone quite early, 1 to 2 milligram per kg. That's with a maximum dose of 60. Some literature actually say go up to 40 milligrams actually, not milligrams per kg, but 40 milligrams or 60 milligrams is max according to what I've written over here. And we give this for 3 days. You can actually give it in divided doses, or you can give it all at once for 3 days. Now remember also that the prednisolone usually comes in 5s, multiples of 5s. So if you get like a dose of maybe 34, you can round it off to 35 milligrams. If you get a dose maybe of 22, you can maybe round it off to about 20 milligrams. And then if they're not improving, then we continue to manage them as a moderate exacerbation. If they are improving, we observe them, like I said, for 60 minutes after the last dose, and then we discharge them. When we discharge them, they'll be going home on this prednisolone that they'll continue for 3 days. Then they'll also have this regular bronchodilator that they'll use for about 4 to 6 hourly for a few days, for this same 3 days. Then after that, they can use it whenever they see or they deem necessary. They should get an early review in about 2 to 4 weeks, but these can be reviewed at the local clinic. If they're not improving after 20 minutes, remember checking them every 20 minutes, then we manage them as a moderate exacerbation. So this is what an inhaler, a spacer, and a mask looks like. So we've brought this in the exams for many students. They're not able to recognize this, so please be able to recognize this. Then here's another image of a spacer and an inhaler. So what about moderate exacerbation? These ones tend to be needing some admission, so we admit the patient, we nebulize them. Notice how on mild exacerbation we could either use 2 options. Either we can use the inhaler with the spacer and a nebulizer, but here we want to nebulize them. So we nebulize them if they're less than 2 years, 2.5 milligrams, the 3 cycles back to back. If they're greater than 2 years, 5 milligrams, 3 cycles back to back. We start them also on prednisolone, 1 to 2 milligrams per kg orally once a day. If they are not improving or if they're vomiting, we can otherwise give them IV hydrocortisone at 4 to 5 milligrams per kg 6 hourly. If you do not have IV hydrocortisone, you can use methylprednisolone, 1 to 2 milligrams per kg per dose, 6 to 12 hourly. I want to start these patients on oxygen. So we start them on oxygen about 5 to 10 liters per minute. We can actually give 8 liters per minute via the face mask. We should also, if we're monitoring this patient every 20 minutes and see if they are improving. If they're not improving, we can consider adding ipratropium bromide. 3 cycles again at 20-minute intervals, which we can give via the spacer or the nebulizer. It's ideal if we give via the nebulizer. We can give this 4 to 6 hourly. Remember that the solution comes 1 ml is going to be equal to about 250. This should be micrograms, 250 micrograms. So less than 1 year is about 125 micrograms. 1 to 5 years is about 250 micrograms as a dose. Greater than 5 years is 500 micrograms. And remember, if they're not improving after 20 minutes, we manage them as a severe exacerbation. If they are improving, then we can observe them for 60 minutes after the last dose and then prepare them for discharge. Then what about the management of a severe asthma exacerbation? These ones need to be admitted and especially be taken to the pediatric ICU. So often we want to also start them on high flow oxygen, 5 to 10 liters per minute, just like the patients with moderate asthma. We also use salbutamol when we nebulize them. So again, the 3 cycles back to back of 2.5 milligrams less than 2 years, as well as the 5 milligrams greater than 2 years. Now, after we nebulize these patients with salbutamol, we're going to follow this up with IV salbutamol, which is going to be a continuous infusion. And remember that this continuous infusion is going to be starting at 0.5 to 1 micrograms per kg per minute. And then after that, we can actually increase by 1 microgram per kg per minute every 15 15 minutes to a maximum dose of 20 micrograms per kg per minute. Some people actually prefer to actually start off by giving a bolus. So you can actually give a bolus of about 5 to 10 micrograms per kg over 10 minutes, and then after that switch to the infusion at 0.5 to 1 microgram per kg, then increase according to the response. We also want to start them on ipratropium bromide via our nebulizer, 4 to 6 hourly, 3 cycles at 20-minute intervals. If they're less than a year, 125 micrograms. If they are 1 to 5 years, 250 micrograms. If they're greater than 5 years, 500 micrograms. We also give them prednisolone or IV hydrocortisone in this case, because they may actually not be able to take orally IV prednisolone as well. IV methylprednisolone or IV hydrocortisone at the same dose as moderate type of asthma. Then if they're still not improving, we can actually consider giving them IV aminophylline, so about 5 to 6 milligrams per kg as a start dose over 20 minutes. That's if they haven't taken theophylline before. So once we've given this, then we can actually give them an infusion at 0.5 to 1 milligram per kg per hour. And then also do consider magnesium sulfate. And remember that aminophylline is not supposed to be used as a first-line treatment of acute exacerbation of asthma, except if you have no other option or no other alternatives and you have actually used up all the other drugs that you have, then you can consider using it. Regular reviews are actually needed for these patients that actually do come in with severe asthmatic exacerbations. Then what about a life-threatening attack? So these ones, we manage them just exactly as we managed the severe exacerbation. So admit them to the pediatric ICU. We start them on the salbutamol nebulization, salbutamol IV, just like I discussed in the previous slide. We give them oxygen, high flow oxygen. We start them on our hydrocortisone. If we don't have that, we can give them our methylprednisolone. In addition to this, we want to do certain investigations such as a full blood count, ESR, UNEs, blood cultures, and arterial blood gases if available. We want to start them on magnesium sulfate. Intravenous magnesium sulfate 50%. We give it at a dose of 0.1 mils per kg. That's 50 milligrams per kg over 20 minutes with a maximum of 2 grams. And we dilute this as 1 to 5 in 0.9% of normal saline. And remember that this is going to be considered as an adjunct to whatever you're doing as the management of severe acute exacerbation. So we add magnesium sulfate. If still they're not responding, we can consider giving them adrenaline. So subcutaneous adrenaline 1 to 1000 at 0.01 milligrams per kg with a maximum dose of 0.5 milligrams per kg, and IV aminophylline, the same dose as the patients that had a severe asthmatic attack. Now remember that adrenaline and aminophylline again should not be used as the first line treatment for exacerbation of asthma. In situations where the other drugs that can be used, they should be used in situations where there are no better alternatives. And regular reviews for these patients are needed because these patients often tend to actually deteriorate even much quicker, and they can actually slip into a coma and eventually die. And then what you really need to take note, like I say, the reason why we don't use adrenaline and aminophylline is because of their toxicity. So these drugs are often just limited to the ICU. We often want to monitor our patient's pulse, their color or presence of cyanosis, peak expiratory flow rate, their ABGs, and their oxygen saturations. We monitor them at least 4 hourly. We keep all our patients that are admitted for an acute exacerbation of asthma hydrated. Remember, every time you're breathing out, you're losing this water from your respiratory system and you're using energy. So it means that you should add a fluid that has some form of dextrose to it, and it should be your maintenance fluid to replace the insensible losses. Avoid any chest physiotherapy as this may increase patient discomfort. Antibiotics should only be given for cases where you suspect that there's a superadded bacterial infection. Avoid any sedatives or mucolytics, and remember that the efficacy of prednisolone in the first year of life for those that are 1 year is actually quite poor. Now, what's our discharge plan after we've not gotten this patient out of this asthmatic attack? And remember, whenever you're reviewing the patients, they should be improving in terms of the vitals. Their respiratory rate should come down, their heart rate should normalize, the saturation should be above 95% to be on the safe side, but some even use a lower threshold of 92%. And in addition to this, they should be able to speak. They shouldn't be on oxygen. They shouldn't be dependent on oxygen. So they should be able to speak, and their vitals should be stable on room air. That's when you can, if they're stable, at least for the past hour, for those that have been having the mild to moderate exacerbations, and about 4 hours for those that have been having the severe and even the life-threatening attacks before you can actually discharge them. So the patient can actually be discharged when they are on 4-hourly salbutamol inhalation, and they should complete the 3-day course of prednisolone. And of course, you should educate the patients whilst they're on the ward on asthma, the certain triggers, and how to use the inhaler. Those that actually have a mild exacerbation, like I said, can be reviewed from the local clinic. Those that have moderate, severe, and even life-threatening exacerbation should be booked to be reviewed in asthma clinic. And remember that the risk factors, you should actually check for them and correct any modifiable risk factors. You should teach them about the triggers. If dust is the trigger, tell them to avoid all the triggers that can actually lead them to an asthmatic attack. And have a written plan for this patient that you discharge or before you discharge. So these plans should include how to recognize worsening symptoms of asthma, so teach the patients on this, how to treat worsening asthma, teach them on this, and how and when to seek medical attention. When to tell that this child is not improving, let's take them to the hospital to seek medical attention. And if you do this, asthma is actually going to be quite well controlled, and the frequency of them coming to the hospital is going to be less and less in the future. I really hope you enjoyed this video on acute exacerbation of asthma. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss any notification of such amazing content every time I post. Until the next video, my name is Dr. Moses Kazevu, to Zambia and beyond. Until next time, bye-bye.